probably one of the most important ways.
Dr. Mangesh? Can you hear me, Dr. Mangesh?
Yeah,
Hello?
I can hear you. I can hear you. Tell me, sir.
Yeah, can I just look at my PowerPoint from here? Can I,
please share.
So I need to share the screen?
Right, sir. You can share the screen. You can try. You can try once. Now it's 6:30. 6:27. Yeah.
Can you see that?
Yeah, we can see that. Yeah. Avinash, are you able to see this?
Yes, sir. Yes, sir. We can see, and we are also live on Facebook.
Yeah, we are live on Facebook. Thank you.
Okay.
Shall I try sharing my screen once?
Praveen sir has to stop sharing. You can stop sharing.
How do you do that? Yeah.
Yeah.
So I will just try once and then we are on. Yeah, can you see it? Yeah.
Yeah, we can see, sir.
Oh, then I will stop sharing. Fine.
Yeah.
I think only Suresh has left joining. Suresh and
Suresh and
okay, everybody has joined. I think then Nitin is there.
Suresh and Ashish.
Suresh and
Ashish Nabar.
Ashish Nabar, I have talked to both of them. They are just joining.
Ashish sir has joined now.
I think we can start at any time. It's already 6:30.
yes, so we should start it because it's a long session. There are a lot of other meetings.
Right.
Okay. Good evening, friends. On behalf of Indian Society of Electrocardiology, I, Dr. Ketan Mehta, Honorary General Secretary, invite you all for today's symposium on hypertrophic obstructive cardiomyopathy. Friends, as all of you are aware, the Indian Society of Electrocardiology, which was established in 1972 and has always been in a forefront of doing the academic activity. In fact, during this lockdown also, as you must be aware, we have conducted a series of webinars, including basic and advanced certificate course on electrocardiology. Friends, in today's time, all of us have changed our practice pattern. Majority of you are either converted into a consultant covidologist and remaining have become consultant webinarologist. So today, what we are going to have a different spectrum, and that is on hypertrophic obstructive cardiomyopathy, which is a very common entity and not commonly discussed about. And to discuss each and every aspect of HOCM, we have eminent faculty with us. And to take you through this, may I invite our Vice President of the Society and a senior physician, Dr. Ramesh Dargad, who is attached to Lilavati Hospital and Seven Hills Hospital, to take you forward. So over to you, Dr. Ramesh Dargad. But before that, I would make one request. This session, we want to be an interactive session. So after each session, there will not be a Q&A, but you can note down your queries. We will have all the questions which will be sorted out at the end of the session. There is going to be a separate Q&A session. So that's very important. We want more and more active participation from the delegates. Second request would be, when one speaker is talking, may I request the other panelists to keep their on a mute view so that there is no disturbance when the one person is speaking about. So over to you, Dr. Ramesh Dargad, please.
Thank you, Ketan, for this welcome, Steve. And now we're going to have this, as you told, is very important session on HOCM. The reason why we started for this HOCM, there have been two major developments have happened. I think there is the first time some new drug has been introduced in the ESC, which will be discussed today, which has some role, definitive role, all over the symptomatic beta blocker, Norpace, what we used to use. And I think surgical therapy has now become little progressive in India, with at least 2 to 3 centers doing. And we have 2 people from the Kochi who have been doing excellent work, and from Delhi also. So these are the 2 main objectives. I just actually of this today's symposium, which we're going to have on HOCM. And we have really a galaxy of speakers at the national level who have done a pioneering work, all this thing. First talk will be, of course, Dr. Gupta will going to look after the overview. Of course, Dr. Gupta sir doesn't need, he's the president of this main pillar behind all these electrophysiology programs and everything. He was with Railways and Asian Heart Hospital. So he is going to talk on overview of that. And then, of course, the next speaker, we have Dr. Nitin Burkale. Of course, he also he's from Mumbai, so doesn't need much introduction. He has helped us in the last program of a TAVI very well on the electro. He's going to talk on the 2D echocardiography in the HOCM, which is a very important part of diagnosing it. And of course, there is a vast experience in electrophysiology. He has been the pioneer in this field, and I organized the national level of this conference, and is attached to Jupiter Hospital. And he has always helped us in last time also our program in TAVI. He helped with very short notice. So Dr. Burkale will be talking on electrophysiology on the hypertrophic obstructive cardiomyopathy. The next, I think, speaker is Dr. Hesham. I think we had a pleasure of talking to him last week only. And then, of course, Dr. Venugopal introduced me to him actually, who is his guide, and he's been very active member at the Kochi, at the Amrita, and he's a clinical professor and co-guide to the Center of Aortic Disease and Marfan Syndrome. They have taken up, I think, HOCM in a big way, cardiac heart transplantation, Amrita, hypertrophic cardiomyopathy. I think since 1913 they have been started, and last 2-3 they have been quite actively doing this work. They have also an oncology clinic and cardiovascular genetic services, which are an important part in the hypertrophic cardiomyopathy clinic. And he is one of the looks of the medical part, along with the team of the Praveen Verma, who is going to look after the surgical. So this is one of the centers. I think they perform more than 30 surgeries without a single mortality, and one of the now renowned center in India for the HOCM surgery and management. Our next speaker, of course, is again from Mumbai. We don't need any introduction. He's been a pioneer, Arrhythmia Associate Program, last 25 years in electrophysiology and various CMEs. Has been a very active member, ex-professor, associate professor at the KM Hospital, and vice president of this Electrophysiology Society, and been very active. I think Amit doesn't need an introduction. Of course, you all have heard him many times, and of course, always is lucid and very solid presentation from it will be there today. And of course, Dr. Suresh Vijan, my colleague at Lilavati, of course, I today heard he has done more than 500 septal ablation, has been also elected physiology and cardiology associated with Lilavati and Fortis, and probably 3rd largest series in the world, probably, because septal ablation comes from India. He was one of the first who implanted ICD in Mumbai and pioneered in these techniques of the dual chamber pacing and all that, India. And I'm very pleased to be, he's my colleague and I think he will share his experiences on the septal ablation with a hypertrophic obstructive cardiomyopathy. And our next speaker is, of course, surgical colleague of ours, actually from Kochi, who is going to be talking on the surgical management, which is most interesting, I think, the recent advance, which has now become available to India, and he's been trained for this actually. He's at Amrita along with Dr. Shim and their team. He's reviewed the numerous journals and editorial board of this cardiac anesthesia and co-authored more than 40 publications. And I think he's going to share his experience of their surgery at the Amrita Institute of the Center about the HOCM surgery, of course, about along with other Marfans and all that. They've been doing a lot of congenital this work actually, and with a big volume they are doing at Amrita. So I think that is our galaxy of the speakers actually. So I think our first speaker will be Dr. S.B. Gupta. We're going to just take the overview of the HOCM, and then we will have Nitin to talk on echocardiography. So I'll request Dr. Gupta sir to start on his presentation on the HOCM, just overview of that, and it will be a short overview. Over to Sir Gupta sir.
Thank you, Dr. Ramesh, Dr. Ketan, and Dr. Ashish for being the moderators for this session. And I'll just share my screen, and my screen is visible?
Yes, visible, sir.
Yeah. So I'll be just taking you through hypertrophic obstructive cardiomyopathy and overview. Basically, this disease has been called by different names, like hypertrophic cardiomyopathy, which says that it's non-obstructive. Then we have got HOCM or hypertrophic obstructive cardiomyopathy. And sometimes we call it as asymmetrical septal hypertrophy, ASH, which tells about the hypertrophy of the septum causing the obstruction. Or sometimes we say apical cardiomyopathy, where only the apex of the LV is involved, and then we call it as apical cardiomyopathy. So there are so many names for this disease.
Sorry.
Yeah, so basically this is a global disease, a worldwide disease, which is due to abnormal hypertrophy of the myocardium resulting into LV outflow obstruction. It's basically a genetic disorder with autosomal dominant inheritance in approximately 60% of the cases. And the remainder, about 40% of the cases, may be because of the spontaneous mutations. Most patients of HOCM are symptom-free and diagnosed incidentally. A group of patients are quite symptomatic, and they present with angina, syncope, or arrhythmias. And the most common concern of HOCM is sudden cardiac death in young individuals, especially the young athletes. HOCM is usually equally distributed in both the sexes, and the prevalence of HOCM is approximately 1 in 500, approximately 0.2%. In United States, the HOCM related deaths are fewer than 100 deaths per year, approximately 1 per 220,000 athletes. The extent and the asymmetry of hypertrophy of the IVS tells about the degree of obstruction. There is a systolic anterior motion of the mitral valve, which leads to dynamic outflow obstruction. And there is, I think, the most important thing in the HOCM is the impaired diastolic dysfunction, which is causes the increased LV pressures and impaired ventricular filling. I'll just touch upon briefly about the genetics because I told you this is an autosomal dominant inheritance disease, and the most of the time the mutations are in beta myosin heavy chain or in troponin, actin, or titin molecules. It is inherited as autosomal dominant manner. 40% of these mutations occur in beta myosin heavy chain on the chromosome 14q1, and 40% happen in the cardiac myosin binding protein C gene. So this makes almost 80%. If the mutation is in troponin T, then it's more harmful because it's associated with almost 50% mortality before the age of 40 years. I told you the majority of the patients are asymptomatic. The shortness of breath is the most common presenting symptom. Patient may have pre-syncope, syncope, anginal pains, and/or palpitations. Most of the time, exertion usually precipitates the symptoms. Sometimes, usually the patient who are symptomatic and have got severe disease may have heart failure, paroxysmal nocturnal dyspnea or orthopnea. I told you the sudden cardiac death is the most devastating presentation. In most of the cases, the physical examination is usually inconclusive, but sometimes patient may have raised jugular velar pressure, prominent A wave, S4 systolic ejection murmur, features of left ventricular hypertrophy, mitral regurgitation, or they may show a double carotid pulse or double apical impulse. Hand grip and the beta blockers increase the ventricular volume, thereby decrease the LV outflow gradient and decreases the murmur intensity. And the reverse happens with Valsalva maneuver. For the diagnosis, BNP may be abnormal. X-ray chest show left ventricular hypertrophy. ECG again may show left ventricular hypertrophy. Sometimes, especially in deep apical cardiomyopathy, we get deep inverted T waves in anterior leads, especially with apical hypertrophic cardiomyopathy. Patient may show atrial fibrillation, which is a very common arrhythmia, and ventricular arrhythmias. 2D echo is the investigation of choice and remains the primary imaging modality, which will be discussed in detail by Dr. Nitin Burkle. 1/3 of the patients have resting obstruction and increases on provocation. The obstruction is graded as the gradient across the septum, which is more than 30. 1/3 of the patient have normal gradients on rest and increases on provocation. And 1/3 of the patients have got normal gradients both on rest and on provocation. Cardiac MRI is again a gold standard as far as the choice of modality for imaging, but shall be performed if the diagnosis is in doubt. We normally do not perform cardiac MRI in each and every case, but if the diagnosis is in doubt, then the cardiac MRI is performed. Cardiac cath and CAGs are rarely required, and genetic testing can be done in the index patient where there is a very, suppose there is a sudden cardiac death in the family, or patient is of high risk on stratification, then the genetic testing can be done. This is the one electrocardiogram in hypertrophic cardiomyopathy, a typical electrocardiogram where you see a sort of a left ventricular hypertrophy pattern with STT changes in the lateral leads. Treatment will be discussed in detail by our 4 faculties, Dr. Hisham Ahmed, Dr. Amit Vora, Dr. Suresh Vijan, and Dr. Praveen Verma. But the treatment is basically medical treatment to begin with, where I think age-old drugs like verapamil and beta blockers are being used. Nowadays, there are a lot of literature is on disopyramide, paraxylene, ranolazine, L-clazine, and nowadays there are a lot of target therapies are being investigated. Then we have got septal reduction therapy, which is alcohol septal ablation, which will be discussed by Dr. Suresh Vijan, and septal myomectomy, which will be discussed in detail by Dr. Praveen Verma. Then sometimes for treatment modality, which is almost an obsolete thing, initially it was being tried, the dual chamber pacing for treatment. And then we have got antiarrhythmic therapy and how to prevent sudden cardiac death in HOCM. That will be discussed by Dr. Amit Vora. So just to conclude, hypertrophic cardiomyopathy has got a very wide spectrum of clinical presentation, from asymptomatic to very symptomatic presentation. The cause of concern is sudden cardiac death, especially in young athletes. Treat or not to treat depends upon symptoms and risk stratification. Beta blockers are still the mainstay in the medical therapy. Septal reduction therapy shall always be sought in symptomatic individuals. Thank you for your kind attention.
Thank you, Dr. Gupta sir, actually for this overview of this HOCM. And of course, we India don't know exactly data, but I think 1 in 1,000 or something, the data epidemiological studies show, and it's not a very uncommon thing to see, but which to be treated, I think will be decided. And to put that, echocardiography will be very useful. So to summarize that, I think Nitin Burkle will take up the echocardiography in HOCM and its importance and how to diagnose it. Because MRI may not be practical in every patient, so it may be ideal, but I think echo remains the primary screening method for all of us. So over to you, Nitin.
Is my skin visible?
Yes, visible, Nitin. Huh?
Yeah. Thank you, Dr. Dargat. And thank you, Dr. S.B. Gupta, for for giving the entire background of this symposium, so that I can just focus on to imaging. Hypertrophic cardiomyopathy has always been a novelty for the imagers. Let us look at the different shapes of the hypertrophic cardiomyopathy. You have this reverse curvature where there is a convexity towards the LV cavity, and that is generally the one which you will have the hypertrophic cardiomyopathy, SM and MR. Then there are sigmoid shapes like this, where you have got a bulbous basal septum. Then you have got neutral septum. You just have the asymmetric hypertrophy, but there is no curvature there. Then you have got apical hypertrophic cardiomyopathy, which may be just a thickening at the apex, or you have a thickening with a very small channel in the center. And these are the very difficult to pick up if you are not using LV opacification contrast, because most of the time the apex can go into the apical clutter. Then you have got this mid cavity one, which is most dangerous. It causes a lot of angina because of subendocardial ischemia, and this LV pouch can also produce clots and can have arrhythmias. Now, these different variations in the septum also are represented differently by the mutations. And if you see the reverse one, where it was a convexity towards the septum, almost 80% of them will have some mutation. And as was discussed earlier, almost 60% of them will be either the myosin heavy chain or the myosin binding protein C. What is a pathological LVH? Now the criteria is the IVS is 16 mm or more. Why this number has come? If you see the highly trained athletes, the Afro-Caribbean highly trained Olympic grade athletes, almost most of them would not cross 15 millimeters, and there had been only 3 cases showing a 16 millimeter thickness. So anything above 16 millimeter is not physiologically possible. And if you have an asymmetry of IVS to PW more than 1.3 or non-contiguous, that means you may have a particular area or a particular segment in the LV which is only hypertrophied. And this one will get only if you are using an LV opacification contrast or you are using an MRI. Secondly, this systolic anterior motion and elongated mitral leaflets are very characteristic of a sarcomeric variety of hypertrophic cardiomyopathy. So also the myocardial crypts which you see on the MRI. Obviously, the family history and the exercise capacity less than 80% for the age and gender matched peak VO2. If you have all this, think of sarcomeric hypertrophic cardiomyopathy and then do the risk stratification. Now, there is always this concern that we are not missing an athlete's heart. Now, let us look at these 2 ECGs. Both of them are having T inversions, but one of them is a highly trained athlete and another one is a hypertrophic cardiomyopathy and who is also an athlete. If you see this particular first ECG, the number A, you can see that there is a T inversion from V1 to V3 to V4, but it doesn't cross V4. There is a J point elevation more than 1 millimeter in V2, V3, and there is a convexity. Actually, this pattern goes with the highly trained athletes. While this particular person on the B is a hypertrophic cardiomyopathy and he's also an athlete, you can see the T inversion has gone all the way to V6, also to 3 AVF. There is no J point elevation, though there is a convex ST elevation. So actually a J point elevation is a good thing. And if the T inversion is not going beyond 4, very likely that this is a athlete's ECG. Then there are certain echo parameters which favor an athlete. The large LV cavity size favors an athlete. LA dilatation, which is moderate, favors an athlete. While then LA dilatation is much significant in hypertrophic cardiomyopathy, a symmetric pattern of hypertrophy, no LVOT dynamic obstruction, normal LV longitudinal function, that is E prime, S prime more than 9 and E by E prime less than 7. And if you detrain the athlete, the LVH regresses in 8 to 12 weeks. Now, echo surveillance is required in the first degree relatives and for the screening purpose before the cascade genetic testing. Then in an adolescence, you do the echo 1 yearly, because as you know that half of them present by the adolescence and 3/4 of them present by 6th decade. So it is better that after in the adults, every 5 yearly, you have an echo surveillance in the first degree relatives. While for an asymptomatic HCM, it is okay to do the echo 1 or 2 yearly. Now let us look at the cases. Now this is a very generic case, a 52-year-old male, asymptomatic, weight 67, body surface area 1.7, normal blood pressure, known case of hypertrophic cardiomyopathy, family history of sudden cardiac death, both on maternal and paternal uncles. And this is the ECG, where you actually have a J-point depression. There is a T inversion, which is 2,3 AVF and V2 to V6. And this is his echo. You can see the asymmetry here. You can see a chordal SAM there. Now, what is important is to look at the intrinsic abnormality of the mitral wall leaflets, which is present in almost 12% of HCMs, which is like papillary muscle directly inserting into the AML, or a shortened AML and a longer PML, so on and so forth. So not always the MR is due to dynamic LVOT or SAM. This is important from the surgical perspective. Now, this patient doesn't seem to have much of an LVOT at rest, but as you know, 1/3 of them are precipitated by exercise. Here, the IVS, which is 25 millimeter, and the M mode is still helpful to look at the subtle SAM. And if you do the color M mode, actually it picks up the SAM and the turbulence in the LVOT much better. These are the short axis views. A series of them is very important to not to miss a non-contiguous variety of hypertrophic cardiomyopathy. Now, these are the long axis views, and this is a apical long axis view, which we prefer to take the dynamic LVOT obstruction, so that your CW sample does not get contaminated by the mitral regurgitation. There is no dynamic stenosis in this particular patient, and these are the strain analysis. Now just look at the hypertrophic septum. Actually, it has the worst strain, because this hypertrophy is not healthy. This is because of interstitial fibrosis. So you will get this variegated appearance of the strain map. And what is interesting is that the area which is having the most hypertrophy actually has the least amount of strain, and that is very characteristic. You look at the LA volume. Any volume more than 34 ml per meter square is abnormal. Remember, 1/4 of the hypertrophic cardiomyopathy patient present later with atrial fibrillation. So do not overlook the LA and LA dilatation. Now this is the E by A and the E by E prime showing a restrictive filling pattern. We can also look at the basal rotation and the apical rotation, which tell you about the twist function of the left ventricle. And this is the apical twist, and most of the LV ejection is achieved by the apical twist in the hypertrophic cardiomyopathy, like the ringing motion of the LV, because the longitudinal LV contraction is quite reduced. The apical rotation, the untwisting of the LV apex is very slow, and that is why they have got a significant problem with the LV suction in the early diastole. That is why they have got a very impaired exercise capacity. Now, CMR actually adds very little to it, because especially from the point of view of the morphology. However, where the CMR adds is actually looking at the myocardial characterization. Now here we are seeing the LV short axis stack, which is the SSFP images, and then you can see the late gadolinium enhancement put side by side to it, and you can make out the late gadolinium enhancement, which is more at the insertion side, which is actually a non-specific thing, but more amount of myocardium involved, you know that there is more amount of interstitial fibrosis and higher chances of having the arrhythmias. Now there are software algorithms to pick up the fibrosis. Now there are various ways you can have, say, a standard deviation of 5 such standard deviation to look at the late gadolinium enhancement, 4 standard deviation, 2 standard deviation, or half width full max. All these full width half max, I mean, so all these can give you different numbers for the amount of fibrosis. So generally we are very rigorous. We go by 5 standard deviation, and anything going above 15% of the myocardium, there is a higher risk of arrhythmias. The T1 value or the T1 map of the myocardium is a latest in thing, and the T1 values on a 3 Tesla are around 1150. Now these are the values in this patient which are gone 100 milliseconds above. And after giving the gadolinium, you can have extracellular volume fraction measurement, which tells you the amount of interstitial fibrosis. And if it is more than, see, generally the normal is around 20%. Anything going above 25 or 30% suggests a significant interstitial fibrosis. The risk stratification depends upon the maximal wall thickness more than 30 millimeter, EF less than 50%, apical aneurysm in mid-cavity obstruction, dynamic LVOT with a gradient above 30, LA dilatation above 34 ml per meter square, dyssynchrony, late gadolinium enhancement more than 15%. But here you have to be very careful the way you are measuring the amount of fibrosis, perfusion defect on SPECT, and reduced CFR. All these are the risk factors for heart failure and sudden cardiac death. Now there is another application which is the myocardial contrast echo in hypertrophic cardiomyopathy, and the ACC consensus document says that it is very useful in guiding the alcohol septal ablation, because it tells you about selection of an appropriate septal perforator, because many times the first septal perforator may not be supplying the touchdown point of your SAM, and it may be supplying much wider area, or it may be supplying aberrantly also. And I'll show you one of such case. Now this is the hypertrophic cardiomyopathy on the table on the cath lab, and you can see images would be a little poorer, because as you know that they can't turn leftwards, but you can see that there is a significant SAM, and this is the touchdown point. Now when you inject the contrast into the first septal perforator, the base should get illuminated. So the right coronary is perfectly fine. You have got your pacemaker wire in. This is the good first septal perforator, and then you can pass the wire into the first septal perforator and put the balloon over the wire. And when you remove the wire, inflate the balloon, and you can inject the contrast into the septal perforator. So we'll inject the contrast into the first septal perforator after inflation of the balloon, and that also tells you that you have got a perfectly snugly fitting balloon there, and nothing is going into the LAD. And after removal of this wire, we'll inject the myocardial contrast, which is a lipid-based molecules, and they have got a lipid shell, and inside there is a inert gas, and that produces an intense contrast. And you can see there's an intense contrast at the base of the septum, and everything looks very fine. But let us look at other territories. So very carefully, you look at the right ventricle, and you can see that the tricuspid papillary muscle is also illuminated. So remember, that means the first septal perforator is not only supplying the base of the septum, but is also supplying the RV and the papillary muscle. It would be disastrous to inject alcohol here, because it will produce a massive TR. So the thing is, if the largest literature from Dr. Sigweiss, they have found that these septal perforators can supply the inferior portion of the LV, posterior wall of LV, sometimes the papillary muscles of the LV or RV side, RV free wall, so and so forth. And the incidence can be as high as 11 to 12%. So if you use a myocardial contrast for alcohol septal ablation, you have got a shorter intervention time, shorter fluoroscopy time, fewer occluded vessels, smaller amount of ethanol used, smaller infarct size, lower likelihood of heart blocks. So I think we have 2 minutes to squeeze in another case. This is a 51-year-old male, class 2, known case of cardiomyopathy since 1996, had a serial echo surveillance. There's a progressive fall in ejection fraction over the last 5 years. He's non-hypertensive and non-DF. And this is his ECG, very poor R-wave progression. Apart from that, I think there is nothing great about it. And this is his echo. Now, this looks like a dilated heart, but the thing is, the septum in one view looks thin, another view looks thick. There's a posterior wall which is partially thin, and there is not much mitral regurgitation. But you look at the short axis, and there are areas which are small, areas which are hypertrophied, again some areas which are thinned out, and globally hypokinetic. You really don't know the origin of this kind of a dilated cardiomyopathy. This is an IV contrast, and then you can delineate the LV cavity better, and you can see that there are areas which are having certain crypts also, certain areas which are thinned out, while there are certain areas which are bulbous. So these are when you see such kind of LV areas, some of them thick, because many times the hypertrophic cardiomyopathy can advance into a dilated phase, and the areas which were thick earlier because of fibrosis can start becoming thinner. So these we can pick up by the LV opacification contrast. The strain map is all variegated, showing areas of fibrosis. And this is the left atrium. Not only the volume is enlarged, but the left atrial strain is significantly reduced. Normally it is around 40%. It is just 15%. And then there is a restrictive filling pattern. The LV angio, the coronaries are perfectly fine. And then we look at the MRI images. And if we put the late cardiac enhancement, you can see so many areas of patchy fibrosis all over the left ventricle, and this is the perfect pattern which will be there in an advanced state of a dilated cardiomyopathy, advanced state of hypertrophic cardiomyopathy, which has gone into dilated phase. That's something like a burnt out hypertrophic cardiomyopathy. And these are the patients with low ejection fraction and such an extensive area of late ganglion enhancement are the ones which are the ones which have got a very high chances of sudden cardiac deaths. And you can see the T1 map showing areas of very high T1 values and extracellular value going above 33%. In the interest of time, I will stop here. And I think at the end, we'll take questions. Thank you.
Sir, Dr. Hisham.
You have to unmute yourself.
Yes.
Ramesh sir, you can unmute yourself.
Thank you, Nitin, for your excellent talk. I think the next talker is Dr. Hakeem, who is from Kochi and going to talk on the medical management of HOCM. The beauty of these webinars are that we can get any faculty from any corner of the India or world without any travel disturbance or anything spending that time. So I think Dr. Hashim, who has been doing a good work at Amrita. So over to you, Dr. Hashim.
Thank you, sir, for your generous introduction. And at the outset, let me thank the Indian Society of Electrocardiography for inviting us from Cochin. It's indeed a privilege to be with you today evening. Can you see my slides?
Yeah, you can run the slide.
Yeah, sure. Yes. Once again, thank you for inviting us. So today I'll be taking the discussion into the area of drug therapy of hypertrophic cardiomyopathy, and I'm sure this is an area which all of us are very familiar with. And so over the last 6 decades, there have been certain dynamic changes in the way we approach patients in terms of pharmacotherapy of this condition, both the obstructive as well as the non-obstructive form. And so this, I did not structure this as a very exhaustive review of the whole process. I would just highlight the areas in which there are certain dynamic changes have occurred. And I'm sure most of us are familiar with the basic principles in terms of application of common pharmacological agents to treat this disease. So I thought I'd just structure it like an update of medical therapy in HCM. So I thought this would be the outline. So pharmacotherapy in HCM can be discussed in the outline of the various clinical scenarios in which we encounter patients in our clinic. We can look at the obstructive HCM phenotype, the non-obstructive HCM phenotype, and we can look at it through the prism of arrhythmias and end-stage disease, or the progressive phase of HCM, and of course, novel therapeutics, which have been quite interesting, especially with the release of a very interesting trial at the recently concluded ESC proceedings. So in summary, if you look at the clinical scenarios, and I think this floral diagram would summarize it. So I would like you to draw your attention to the blue flower area, where you can see that HCM can have various clinical scenarios. So they can present with a diastolic dysfunction, microvascular ischemia. They can present with the heart failure spectrum of symptoms. They can present with arrhythmias, commonly atrial fibrillation, and of course, ventricular arrhythmias. And definitely, I think as elegantly shown by Burkle sir, that they can present with left ventricular outflow tract obstruction, of course, the classic variety being the hypertrophic obstructive phenotype. So these are the clinical scenarios to which we aim to apply our pharmacological armamentarium. So before we go to the pharmacological armamentarium, it's quite clear that over the last 6 decades, it's quite clear none of the drug agents have been shown to actually modify the mortality in these patients or the disease outcome, or none of them have been found to be disease modifying in large clinical trials. However, the main function of these agents that we'll discuss in the next few slides is to control the symptoms, improve the quality of life, and decrease the risk of complications. So that essentially is the goal of pharmacological therapy in hypertrophic cardiomyopathy. So moving on to the first phenotype, that's the obstructive HCM phenotype, which we're all very commonly aware of. So essentially, beta blockers remains our first choice. And if you look at the review of the data that we have over the last 4 to 5 decades, so the beta blocker journey started in 1960 when propranolol was first described as the agent of choice by the legendary Eugene Braunwald. And nowadays we have a much more wider variety to choose from, including atenolol, nadolol, bisoprolol, and metoprolol. And it is often the first choice due to its mitigating effects in both the resting as well as provocable left ventricular outflow tract obstruction. Now, but if you look at the data, the recent data coming from the European group, and that's especially the data which is coming from the Italian, the Florence group, they usually prefer to use nadolol, and the justification that they provide in the large HCM cohort is that it's more tolerable, it has a 24-hour coverage, and apparently it has a much more favorable electrophysiological profile in the sense that they believe from their 2,000, 3,000 odd cohort of HCM patients that patients on nadolol seem to have a lower propensity for tachyarrhythmias, especially ventricular tachyarrhythmias. So this has to be borne out in large randomized trials, but this has been their collective experience. So the general trend, of course, is to initiate them probably at a quarter of their full dose and titrate them 1 to 2 weeks. And of course, the titration can be based on their symptoms, the blood pressure, the heart rate response, and of course, the adverse effects. Clinically, fatigue seems to be a very common effect in patients when we try to up titrate beta blockers in this subset. Now, of course, when the patient subset is intolerant to beta blockade agents such as verapamil and diltiazem can be considered as a potential replacement. But of course, in a large registry data, we do know that verapamil and diltiazem are not very effective for provocable gradients. So essentially, beta blocker seems to be the choice when we're faced with left ventricular outflow tract obstruction mitigation. And of course, in terms of the evidence, we have a class 1 recommendation at the ESC and a class 1B recommendation at the ACC, similar range of recommendations for the use of beta blockers for this particular indication. Now, of course, we know the target doses, the initial doses and the starting doses. This is just a snapshot of what ranges could be our initiating doses. And of course, on the right-hand side panel, you can see that probably these are the limits to which we can up titrate these drugs. In terms of the second choice, or another clinical tool in terms of obstructive HCM is disopyramide, and this, in fact, has seen something of a renaissance over the last 5-6 years. And probably in the next couple of slides, we'll see why that is. So again, this came out in 1985. It's a class 1A antiarrhythmic. That's what it was initially known for, and it has a potential. It has a very potent negative inotropic effect. So it can be used with beta blockade. In fact, the European guidelines encourage the use of disopyramide coupled along with beta blockade use. It is most effective for resting obstruction. So as I mentioned earlier, beta blocker seems to be the most efficient for provocable obstruction or exercise-induced worsening of obstruction. However, disopyramide has a unique role in the sense that it's also quite effective for resting obstruction. In terms of adverse effects, it has been shown to have something like 5 to 8% of QTc prolongation from baseline. There are certain anticholinergic effects which may interfere with compliance. But then overall, if you look at the large registry data, multi-center registry data, which of the last 5 to 6 years, you can see that it is quite safe and efficacious to use in such a subset of patients. There are certain clinical points that we have to keep in mind, though, that there is a 30% suboptimal response rate if you consider the response rate of a population of patients with HCM. It may lose efficacy over time. And the target clinical dosage, we can aim to something like 400 to 600 milligrams per day. And of course, it can be titrated during an interval of 1 to 2 weeks. In terms of recommendations, as you can see, it has a class 1B recommendation from the ESC, and that is if it's used along with the beta blocker. If it's used alone, the level of evidence is a little less, it's not that high. In terms of the ACC-AHA recommendation, I think it's more or less similar. The difference is only in the level of evidence. So often, if you look at the summary of data of disopyramide in large HCM cohorts in Europe and across the Atlantic in the United States, it often represents a pharmacological bridge to more invasive septal reduction therapies. But having said that, there is a substantial number of patients who do have sustained symptomatic improvement and sustained reductions in LVOT obstructions with this agent, and it is a definite tool in our armamentarium in terms of pharmacological therapy. But it has, as I mentioned earlier, it's come out with a real renaissance in terms of prominence over the last 1 to 2 years. So this was published in 2019, JACC, and essentially this is a very elegant translational study which was performed by Raphael Copini and group. So essentially they looked at why does disopyramide work so well in patients with obstructive hypertrophic cardiomyopathy. We knew from clinical evidence and our clinical wisdom that these patients did rather well over the last, if you look at the data from the last few decades. But for the very first time, I think a group decided to look at why does disopyramide work and what does the mechanism, what does the understanding try to tell us in terms of its clinical utility in such a group of patients. So essentially, just to summarize, what they did was they took samples during septal myectomy surgeries from 20 odd patients, and they looked at cell isolation and dissection techniques and a patch clamp model. And they also had another clinical arm in which they looked at around 39 patients who were started on disopyramide with obstructive HCM. And interestingly, they came up with a few key observations, which essentially explains why this drug seems to work so well in obstructive HCM. So they found that this drug has no direct effect on myofilament contraction. So it's not acting on the myofilament architecture of the cells, but at the same time, it achieves significant reduction in the force of contraction, and that's why its effect as a negative inotropic effect. So they found that it's not acting at the myofilament level. They saw that it reduces significant diastolic calcium. They also saw that it reduces the action potential duration and the after depolarization frequency, which has huge implications in terms of arrhythmogenesis. They also found that it inhibits some of the crucial ionic channels like the peak and the late sodium current, the calcium current, and the potassium currents, and the ryanodine receptor. So essentially, for the very first time, we have very clear evidence in terms of translational medicine, how disopyramide can contribute to, not only in addition to its negative inotropic activity, it has various effects on the cellular architecture and the ionic channel currents, which may explain its clinical utility in patients with HOCM. And in fact, this triggered an editorial comment in the same journal by the Marin's group from Tufts in Boston, in which clearly they said that this is the first translational study which brings for the fact that it's not just an old drug, it's definitely an old drug, but with huge and new implications in terms of the way that it's acting. And therefore, we have now for the very first time a mechanistic explanation for the safety and efficacy of this drug. We also know that the negative inotropic effect does not depend on the myofilament contraction, therefore leading to very minimal ejection fraction drop. And of course, from the ion channel studies, there is a promising antiarrhythmic property of disopyramide with possible implications in non-obstructive HCM, especially non-obstructive HCM patients with atrial fibrillation as well. Now we move on to the second phenotype, that's the non-obstructive HCM phenotype. And essentially, we'll be looking here at patients with the preserved LV ejection fraction subset, because patients with an LV ejection fraction reduced subset is, of course, a totally different subset in HCM. So when you have a non-obstructive HCM subset and you have a preserved LV ejection fraction, you may have symptoms which are contributed by diastolic dysfunction and microvascular ischemia. So essentially, this translates into symptoms such as dyspnea and angina. And of course, in this setting, beta blockade seems to be the rational drug of choice as a first-line drug. And of course, we may tend to use lower doses than that is used for left ventricular outflow tract obstruction mitigation. And of course, in terms of alternatives for a beta blockade, or perhaps to add to a beta blockade to add to its efficiency, we might be able to choose diltiazem or verapamil, which are potential alternatives in these in this subset. There has always been the question of ranolazine, and if you look at the European group data, which is published from mainly from Milan and Florence, they prefer to use ranolazine in large subset of patients of non-obstructive HCM who present with angina. So they do not have randomized control data to support this practice, but I think they have large registry data which seems to suggest that angina relief is possible. It is definitely possible in terms of metabolic modulation in these drugs, especially in terms of inhibition of the late sodium current, and thereby favorably modifying the myocardial energetics. The response is variable, but then there is some clear data from their registries. So to answer the question whether ranolazine can have a similar effect on the exercise capacity or, let's say, congestion and heart failure symptoms, the trial of Restyle HCM came out. And in fact, the trial was largely negative. So here we have a situation where ranolazine seems to be effective, especially in registry data for patients with angina with non-obstructive HCM. But in terms of heart failure symptoms, exercise capacity, and in terms of biomarkers of heart failure, ranolazine doesn't seem to have much of a benefit. Long-acting nitrates have been tried in terms of reduction of angina, dyspnea, and the non-obstructive HCM subset, but with variable response, and is not really recommended. So across the board, most of these agents in the non-obstructive HCM strata of patients, we are looking at a class 2 AC level of evidence, primarily because we simply do not have high quality data, and most of this is based on expert opinion or consensus. Now, if you look at the third phenotype, we're looking at a phenotype where there's progressive disease and end-stage disease. And of course, we know that if you take HCM as a whole, obstructive and a non-obstructive, approximately 10 to 15% of these patients can have severe fibrosis and diastolic function worsening. And of these 10 to 15% of patients who worsen in this way, 1/3 of them can progress to severe systolic dysfunction, or some of them may even land up with a primary restrictive physiology. So essentially, we're looking at end-stage disease in HCM. There are some indicators to suggest that in multiple data registries that we tend to call HCM as having entered an end-stage disease when the LV ejection fractions drop less than 50%. So probably that's because we know that in HCM, primarily the left ventricle is hypercontractile. So any fall in EF of less than 50% in this particular criteria is quite significant in these patients, and probably should be taken as a harbinger of the fact that they have significantly progressed. So of course, standard heart failure medications will come into play, as we do for patients with heart failure with reduced ejection fraction, and they will vary from, or they will include ACE inhibitors, ARBs, MRAs, appropriate beta blockade, especially using beta blockades which have high quality data in the heart failure setting, and of course loop diuretics for congestion. The subsequent speaker, I think Amit sir, is definitely going to speak about arrhythmias in detail, so I will not dwell on this slide. I will just remark that amongst arrhythmias, atrial fibrillation, of course, is the commonest arrhythmia in HCM patients, and of course, ventricular arrhythmias is, of course, the life-threatening category of arrhythmias in these patients. And of course, you have a class of drugs ranging from beta blockers, amiodarone, sotalol, and disopyramide to manage atrial fibrillation, and of course, we have to address oral anticoagulation, or the oral anticoagulation question as well. One key clinical point to note is that the CHA2DS2-VASc score has not been validated in patients with HCM, and therefore, if you have atrial fibrillation in a patient with the substrate of HCM, it's a clear indication of anticoagulation, and of course, provided that the patient does not have a significant bleeding risk. I'll end my presentation with novel therapeutics, and this is where a majority of the interest has been generated, especially over the last 1 or 2 years, and culminating in the landmark trial called the Explorer HCM trial, which was presented at the just concluded ESC. Just to give a background, why do we need novel therapeutics in HCM? Because if you see if you see most of the drugs that we are using in HCM, we see that they are aimed at symptom mitigation, reducing the risk of complications, and probably improving the quality of life. And none of them are really addressing the actual molecular mechanism of HCM. None of them are being specific in HCM, and none of them are actually disease modifying in the true sense of the term. And we have a huge a clinical gap in our understanding in that sense. And that's where novel therapeutics steps in. And of course, I think this is a drug I think which all of us have been hearing a lot about over the last 2 to 3 weeks. And the drug is called mavacamten. And this was a trial which was published in Lancet just a week ago. And essentially, just to simplify the mechanism of action. So essentially, HCM is a condition in which there is enhanced contractility. There is a hypercontractile, high energy state in HCM, if you look at the individual myocyte in terms of energetics. So if you look at here on the extreme left-hand side of the bottom panel, you can see that the purple rod structure is the myosin thick filament. And of course, the myosin filaments gives off cross bridges between the thin red bar, as you can see, and which is the actin thin filament. And this is the normal low energy relaxed state of a normal myocardium. If you move to the second circle on the right in the middle, you can see that in HCM, there is hypercontractility. And why does that happen? That's because, as you can see, compared to the left-hand side picture, you can see there's a lot of myosin cross bridges between the myosin and the actin filament. And that leads to a high energy, low relaxation state, which actually really alters the myocardial energetics. So what does mavacamten do? So mavacamten essentially is an allosteric inhibitor of the myosin ATPase. And essentially it decreases significantly the number of cross bridges between the core of myosin and the actin filament. So, and essentially you are trying to bring down the high energy, low relaxation state to a sort of a low energy, high relaxation state. So we want a low energy state with a high relaxation state. So essentially you're converting it from a hypercontractile state to an attenuated hypercontractile in terms of you trying to attenuate the degree of hypercontractility of the HCM sarcomere. So you want a hypercontractile state to a situation where you want a lower contractile state, and mavacamten seems to achieve this. So essentially, just quickly summarizing the trial, so we're not going to go through the trial data extensively. So essentially, they picked up patients with LVOT gradients of more than or equal to 50 millimeters of mercury and class 2-3 NYHA symptoms, randomized and started oral mavacamten. It's administered orally and with a starting dose of 5 milligrams with titration, and they looked at the results at the end of 30 weeks. Of course, this was a double-blind, placebo-controlled trial, and this is the first, one of the largest, and probably one of the largest double-blind placebo-controlled trials in the field of HCM. So what did they look at? So these are the two endpoints which they looked at. So they looked at an improvement in peak oxygen consumption of an improvement of more than 1.5 mLs per kg per minute, and a favorable NYHA classification response. Or they looked at a composite of these two, in which if there was a more than 3 ml per kg per minute and no worsening. So either one of these two or both together were considered to be the primary endpoints. And of course, there were secondary endpoints at week 30. They looked at the post-exercise gradients, the maximum oxygen, peak oxygen consumption, proportion of patients with NYHA class improvement, and of course, a subjective assessment of the Kansas City Cardiomyopathy Questionnaire. And this is a novel HCM symptom questionnaire. So just to conclude the trial results, so we can clearly see from the, especially as you can see, in terms of the primary endpoint, you could see that 37% of patients in the mavacamten arm attained the primary endpoint versus only 17% in the placebo arm, which was highly statistically significant with a very favorable odds ratio. And if you consider both the primary endpoints, you can see that 20% of patients in the mavacamten arm achieved the primary endpoint versus only 7.8%. And you can also clearly see that the mavacamten arm clearly showed a much favorable reduction in gradients. So the key messages are, this was the largest placebo-controlled randomized trial in HCM till date. We are having the first targeted pharmacological therapy, which really looked at the pathophysiological basis, which led to really clinically meaningful improvements. And of course, long-term data for more than 5 years are necessary. I will end with this slide. So it was the legendary Eugene Braunwald in 1960 when he first identified the clinical series of HCM cases. He said, at this time, we are aware of no method of management that can specifically and favorably influence the course of a patient with this disease. We have now come a very long way, 60 years later, and we have had huge advances in pharmacological and, of course, other therapeutic options, which the subsequent speakers will speak about, in making HCM a truly contemporary and treatable disease. Thank you for your patient listening.
Thank you, Dr. Hashim, for covering this medical management from beta blocker to calcium channel blocker to disomerate and the new addition of marcopyrin drug now available maybe soon to India. So over now, next our talk will be by Dr. Amit Vora, who is going to cover arrhythmia and sudden cardiac death in HOCM. Welcome, Dr. Amit Vora, to talk on the arrhythmias in HOCM and sudden cardiac death. The most dreaded thing actually, sudden cardiac death. Actually, we need to screen the family members and others for early thing actually. So Dr. Amit Vora.
Thank you, Dr. Dargad, and good evening to everyone. So far, it has been a very educative experience, and in the next 12-14 minutes, I'll be talking about hypertrophic cardiomyopathy and arrhythmias. Now, you have a wide spectrum of arrhythmias which are known to be present in patients with hypertrophic cardiomyopathy, and essentially because of the myocardial disarray and interstitial fibrosis, the left ventricular diastolic pressure rising, the LA mean pressure rising. You see a lot of ventricular arrhythmias from ectopy to non-sustained VT, and in some patients it can be fatal enough to cause a ventricular fibrillation and sudden cardiac arrest. Atrial fibrillation is a dominant burden. There are other arrhythmias also, like for example, pre-excitation has been reported in 2 to 3% of patients with HCM. Reports of sinus node dysfunction, atrial standstill, and AV block also are there. But I'm going to primarily focus on ventricular arrhythmias and sudden cardiac arrest and atrial fibrillation, because these are the majority of the major arrhythmias which are seen. So if you look at this graph in terms of arrhythmia burden over the last decade, and this is studied in United States, it's clearly seen that atrial fibrillation is the most dominant arrhythmia seen. Almost 1/3 of the patients with hypertrophic cardiomyopathy have atrial fibrillation. And over the years, the incidence of atrial fibrillation seems to be on the rise. Ventricular tachycardia continues to remain at 5% or so. So this includes the non-sustained VT, which we see. But fortunately, the VF and sudden cardiac arrest, 1 to 2% per year is the incidence. And over the last 10 years, that incidence has remained the same. And in fact, has also gone down with the use of ICDs. If we were to do a Holter study in patients with hypertrophic cardiomyopathy, you would realize that arrhythmia frequency and burden is quite common. But what we are interested in a Holter is to look at the non-sustained VT. And probably up to 30% of patients Holter will show non-sustained VT, and high-grade ventricular ectopy can be seen in almost up to 10% of the patients. It is not very surprising that the arrhythmias tend to occur more frequently in patients who are symptomatic. So those who are a higher NYHA class tend to have a higher arrhythmia burden. And also those who have a LV outflow tract obstruction, they have a higher arrhythmia burden as compared to those who do not have LV outflow tract obstruction. I think let's get on to atrial fibrillation. This is one of the important areas not well recognized and probably a little bit neglected. So atrial fibrillation and arrhythmia, the prevalence is almost 22%. Importantly, the presence of atrial fibrillation, there is a 2.5-fold increase in all-cause mortality in patients with hypertrophic cardiomyopathy driven by atrial fibrillation. it can also cause sudden death. So atrial fibrillation with rapid ventricular rates is known to provoke ventricular arrhythmias as well. So 1.5-fold increase in the risk of sudden death when you have atrial fibrillation. There is almost a 3-fold risk of heart failure. So atrial fibrillation, unfortunately, leads to the loss of atrial kick. These patients have diastolic dysfunction, and obviously they land up into heart failure. And as was pointed out by the previous speaker, thromboembolic risk with atrial fibrillation, 7-fold higher risk of thromboembolism. So clearly, HCM itself becomes an indication for anticoagulating these patients, and there is probably no need to validate with any CHA2DS2-VASc score. What are the predictors of atrial fibrillation and hypertrophic cardiomyopathy? So as I said, if you have a larger LA size, larger volume, increased pressure, compromised function, they are obviously the markers of development of atrial fibrillation. But even late gadolinium enhancement and atrial fibrosis recognition is important. On a simple ECG, a P wave which is prolonged, 140 millisecond or longer, can suggest that these patients are likely to get into atrial fibrillation, and also those who have exercise intolerance and sleep apnea. Now, in terms of management, I think the most crucial and important part is prevention of thromboembolism and stroke. And as we said, that atrial fibrillation in a patient with hypertrophic cardiomyopathy needs to be anticoagulated. You don't need to look at the CHA2DS2 scoring at all, because CHA2DS2 scoring did not consider hypertrophic cardiomyopathy, and there is a very high incidence of thromboembolism with these patients. The next crucial question with atrial fibrillation management is rate control or rhythm control. And though we know that rate control is no inferior to rhythm control overall in management of atrial fibrillation, I would say rhythm control does have probably a higher requirement or a higher need, or should be the first attempt, at least in most patients, because presence of atrial fibrillation does decompensates these patients with hypertrophic cardiomyopathy, and they lead into congestive failure. So rhythm control approach should be considered in most patients, especially when it's a new onset atrial fibrillation. Amiodarone is the drug which has been most tested. Disopyramide has been essentially used for relieving the outflow tract obstruction, but because of its class 1A effect, it may be also useful. Drugs like sotalol, dofetilide, these are the drugs which are generally not considered in patients with atrial fibrillation and HCM, because there is a risk of proarrhythmias and ventricular tachyarrhythmias. So one would use these drugs only if a patient had an ICD as a backup. Now, those who fail rhythm control approach and those who are a chronic, long-standing atrial fibrillation, very large atrium, where you are not going to achieve sinus rhythm, rate control with beta blockers and calcium channel blockers is what should be thought of. And if despite drug therapy, you can't control it, you may add amiodarone as a rate control measure, then AV nodal ablation and pacemaker should be thought of. Now, very select group of patients, a radiofrequency ablation for atrial fibrillation may be attempted, not very large data, not very promising data, but as a last resort, it can be attempted in isolating the pulmonary veins. We can achieve success or reduce the burden of atrial fibrillation. But essentially, it is the atrial fibrosis which drives the AF, and it's very difficult to tackle this with ablation techniques. I think the next important thing is ventricular arrhythmias and sudden cardiac death in hypertrophic cardiomyopathy. And we clearly understand that the most important reason or a predictor or a marker or a risk factor or risk stratifier is a prior history of cardiac arrest. But along with that, a family history of sudden cardiac death, the severity of left ventricular hypertrophy when it goes to more than 3 centimeters, because that leads to scar and fibrosis and microvascular ischemia, which makes them prone to developing ventricular arrhythmias. Those who have non-sustained VT on an ECG or a Holter, apical aneurysm. So, Dr. Burkole showed a nice example of a mid-ventricular obstruction with apical aneurysm. Apical aneurysm can lead to ventricular tachycardia. Monomorphic ventricular tachycardia can happen. It can also cause an LV thrombus. Those who have unexplained syncope, abnormal exercise response, blood pressure response to exercise, and also left atrial dilatation and atrial fibrillation, presence of LVOT obstruction. All these are risk stratifiers for ventricular arrhythmias and sudden cardiac death. Now, it was very early that Barry Maron showed this slide that sudden deaths in hypertrophic cardiomyopathy patients can occur in minimally symptomatic patients, can occur even with sedentary or mild activity. Though we say that, those who are having hypertrophic cardiomyopathy should not take part in competitive athletic sports, which is correct. But many of the deaths do occur with sedentary or mild activity as well. And most often it is the young people who are afflicted with sudden cardiac arrest and therefore needs to be addressed more aggressively. So if you look at all these risk factors, which I mentioned over a period of time, if you follow up over a period of time, I think left ventricular hypertrophy and non-sustained ventricular tachycardia, sustained increased risk over a period of time is noted, as opposed to a remote history of syncope or an abnormal blood pressure response to exercise. So I think these become very important. And that's what has been probably considered when ICD, which is a lifesaver in terms of preventing or aborting a sudden cardiac arrest is concerned, that those who have already an event as a secondary prophylaxis, ICD is recommended. But otherwise, the next important question to ask is family history of sudden death in the first degree relative, LV wall thickness more than 30 millimeters, or a recent unexplained syncope. If you have these, ICD is reasonable choice. If you don't have this, then you look at ECG, Holter, and exercise abnormal BP response, and consider an ICD if these factors are present along with other modifiers. But otherwise, in absence of all this, ICD is not indicated. Now, this has been the American approach. However, European Society of Cardiology has come up with a unique sudden cardiac death risk calculator in patients with hypertrophic cardiomyopathy, where more or less the same risk markers are used, but an elaborate scoring system is given, because we realize that age, as you advance in age, as you cross 50 and 60 years, the chance of sudden cardiac death diminishes remarkably. So a scoring system has been devised based on various risk factors, and you try to predict the cardiac death risk at 5 years, and based on that, the recommendation is given. So if you have a 5-year risk, which is more than 6% of sudden cardiac arrest, then ICD should be considered. But if it is less than 4%, ICD generally is not indicated. And in the intermediate zone, you may consider an ICD implant. What is important to realize is that in HCM patients, sudden cardiac death risk stratification should be done in all the patients. An EP study to identify a high-risk group or a high-risk person who would have ventricular arrhythmias is actually a class 2 indication. So it's not predictive at all, and it should not be considered or should not be done. So I think with this overview, let me summarize a few important messages. One is that atrial fibrillation is the commonest arrhythmia, which drives a higher morbidity, hospitalization, heart failure, stroke, and mortality in HCM patients. Sudden cardiac death risk evaluation should be done in all HCM patients. It may be most relevant in the adolescent and young adults, but it should be considered in all patients. ICD is clearly a life-saving measure and should be offered in young adults. Cardiac MR and genetic testing may play a role in identifying patients at high risk of arrhythmias and sudden cardiac death. I think I will conclude here. Thank you very much for your patient listening.
Thank you, Amit, for covering this arrhythmia and sudden cardiac death in HOCM. In a short time, you covered most of these arrhythmias. Our next talk is on septal ablation, and to talk on that, we have Dr. Suresh Vijayan, who has the maximum experience probably in India, and he'll be sharing his experiences and these on septal ablation in HOCM. Over to you, Suresh.
Okay. Just a second. I'm just trying to get my presentation opened up. Can you see my presentation? No. Oh, great. Now, where did it go?
So you can open the presentation first.
Yep, it's open already.
Yeah, it's open already. Yeah. You can just see in the taskbar where it is open. And just click on that.
That's open now. I'm trying to share it. Sharing is paused.
Ashish?
Yeah, sir.
Yeah,
You
resume
need
share.
to stop share and reshare again.
You can stop sharing, sir, and reshare.
Okay, stop share. And now I'll reshare. Now share screen. Yeah, here we go.
Yeah.
Can you see that now?
Yep, sir.
You can run the slides. Thank you.
Yeah, okay. I cannot. Right. Thank you very much, Dr. Thurgood, for that kind introduction, and my congratulations both to you and Dr. Gupta for actually spending time to set up a full-fledged webinar just on one condition called hypertrophic cardiomyopathy, something that felt has been ignored by most of the cardiology community in terms of giving importance. It's a very important disease. We are seeing more and more young people die from this disease. I'm very happy that we have this seminar today on hypertrophic cardiomyopathy. So far, it's been great from the medical side, and Amit talking about arrhythmias, and I'm going to talk of something which has been very close to my heart for more than 22 years, which is septal ablation for hypertrophic cardiomyopathy. This has been discussed before. The obstruction is in this particular area with a slightly elongated leaflet causing an MR, and the septum's thickened, and we're going to try and reduce that. When would I, first of all, do a septal ablation? Clearly, refractory symptoms despite adequate medication. That's the important thing. A resting gradient of more than 30 or a provoked gradient, usually an ectopic, of more than 50, septal thickness of more than 1.8 centimeters, absence of moderate severe MAR, because that would indicate that there is some mitral valve disease too, which would require to be dealt with, and that would most efficiently be dealt with by a mitral valve replacement and septal myomectomy. And of course, any other associated today, because coronary artery disease is so common that we see so many patients who have both a hypertrophic cardiomyopathy and coronary artery disease. And if the coronary artery disease indicates that there needs to be surgery, then I think the patient should go have a bypass surgery and a myomectomy at the same time. When was TASH or PTSMA, as I mentioned it, first introduced by Ulrich Singwart way back in 1997? First two cases that he did at the Brompton Hospital in the UK, and there was a tremendous resistance to this procedure when it was published in the Lancet. The main thing was, how can we give patients an infarct to treat a disease? There were legitimate concerns about long-term safety of doing something like that in young people and leaving them exposed to fatal arrhythmias over the long period of their lives. And there was an excellent and very critical editorial by Dame Celia Oakley about this. But I think Dr. Singwart persisted with this, and over years, we've joined him to do this case. And now we can clearly make a statement that the long-term safety concerns were not founded. They've not seen anything like that. And I'll just talk to you about what we did. Dr. Burkel has already spoken about the procedures to make my life easy. I'll just highlight a few things. You need to do 3 punctures, RFA, RFV, and LFA. A temporary wire to the RV apex, pigtail to L for LV angio, and a EBU guide for LCA. I usually tend to measure both pressures and do an LV angio and try and provoke a gradient also along with the resting gradient if it's there. I would first cannulate the first septal perforator, the one for wire, and then inflate a balloon in it and identify the target area by using either agitated saline, which is what I used to do for most of the cases. Now we have an echo contrast. Clearly, this has made life very easy. We can now identify sites very easily. This has also led to reducing the amount of contrast we use, amount of alcohol we use, and also we try and create a smaller infarct. Once confirmed, clearly, maximum of 2 to 3, earlier it should be 5, but 3 to 3 ml of absolute alcohol injected through the wire port. But this is done extremely slowly, leaving the balloon open. So you don't want any alcohol to regurgitate back into the LED. You look for hypokinesis. You see that happen on echo. Check for resting and provoke gradients at that time. If you got that, keep the balloon inflated for another 7 to 10 minutes. The time is now gone up from 5 minutes, which was earlier. And once you're sure that you got the gradient down to 0, etc., you need to withdraw the balloon. Now it's very key Careful how you withdraw the balloon. The commonest time when alcohol regurgitates back into the LED when you deflate the balloon with alcohol still being present in the septal perforator. So clearly you need to flush the balloon, the wire port, put suction on the balloon before you withdraw the balloon out of the guiding catheter and out of the system. Then de-air your guiding catheter, allow blood to come out so there's no alcohol left in the guiding catheter before you start taking any pictures. You again check before you're pulling out everything, check an angio. I usually keep the pacing wire for 48 hours. If there are no heart blocks, if there are heart blocks and they don't disappear, then these patients will actually get a pacemaker. I tend to check CPK for 24 hours just to have an idea of what kind of myocardial infarction I've given. Generally, most patients will be mobilized and discharged by day 5 without too many untoward effects. This is an example of what I mean when you do pressures. This is the aortic pressure. This is the LV pressure. And you can see there's a resting gradient of over 100. You create an ectopic here. You can see that. And then the gradient is actually increased by mechanism, which are, of course, an increase in LV pressure plus a reduction in the aortic pulse pressure, giving rise to a much higher gradient, suggesting that, yes, you have a gradient here. Of course, you don't need to do that in that case, but I usually tend to do this. And I try and document this before I start doing the ablation procedure. This is the example of another case where you have actually got a small gradient here. We have an ectopic here, and then you can see the gradient going up. So sometimes a small gradient like this, and this is a bigger gradient, you get an idea of what you need to do and what should be your endpoint before alcohol. So I'll just show you a couple of cases. All right, here we go. That's a patient. You can see this very nice, large, juicy septal perforator. You can see one here at the back, behind the circumflex artery. And here we've entered with a wire. There's a balloon which has been inflated here. The wire's been taken off. We injected, say, agitated saline in this particular case. I identified the target area, then injected alcohol. And once everything has been done, we graduate. And this is something to show you. Here you are. The wire I put back in, and then we deflate the balloon. While I'm deflating the balloon, I inject into the LED. So I make sure that the LED is full of dye, and there's dye going into the septal perforator. So if there's any alcohol left, it gets flushed downstream into the septal perforator. Try and minimize as far as possible any spill into the LED, which would give rise to a nasty myocardial infarction. And this is post-procedure, an angio. You can see the small stump here. The septal perforator has been blocked. And this is the LV gram. This is the first, before the procedure, a hyperdynamic LV. And this is after the procedure. What you really notice is the relaxation. You see the cavities got better and the muscle relaxes. So clearly, you know you've done something good. MR, if it was present, would disappear. And this is post-ablation. You can see this is Valsalva, small gradient coming away. But post-ectopic, there is hardly any gradient. So you know you've successfully done an ablation, and that's taken care of the patient. This is another case. Dr. Burkle mentioned mid-cavitary. Here you can see this patient. Here, actually gone into what is a third septal perforator here before we got an adequate reduction of the gradient, and we successfully performed this procedure. We now have got my results over the last 22 years. I'm talking of 336 patients only because I've done more than 513, but most of those have been done in centers outside of Bombay, outside of Maharashtra, and I really don't have much of follow-up for these patients. So I'm only restricting my talk to these patients for whom I have follow-up. I split them into 2 cohorts because my procedure has changed over this period of time. The first 10 years and the next 12 years. 201 patients in the first cohort, 162 the second cohort, predominantly male. Age range quite wide, 27 to 64, 20 to 68. Commonest symptoms being giddiness and dyspnea on exertion, not responding to medical therapy. Echo gradients at rest were between 40 and 110 millimeters of mercury. Similar gradients even in this second cohort. Associated comorbid conditions were many, as you can see that here, common in our groups of patients for whom we need to treat these. And this is actually a much bigger burden in patients above the age of 40, where they come with both coronary artery disease and septal hypertrophy, referred for ablation, but then I find they have significant coronary artery disease, particularly in the LAD, And actually, a lot of them have responded just to an angioplasty to the LAD. So I've not done a septal perforation for them. What are the results? The resting gradients, as you can see here, 50 to 110, 30 to 130. Ectopic gradients are quite large. Presence of air bar, about 1. Any MR more than 3, I don't do. For the simple reason, I think there is a disease in the mitral valve that requires to be done, so I don't touch them unless I'm absolutely convinced that there is no organic valvular disease that requires to be addressed, and that's for 60 to 70% patient. Post-ablation gradients have been between 10 and 20. Similar kind of results here. And post-ectopic in these patients, again, mild gradients post-ectopic. This is acute results. These gradients go down over a period of time. What about complications? About 8.5% of cases requiring a permanent pacemaker between 19 and subsequently 7.4. Not major difference, which kind of disappointing because I thought that number would go down. Mortality in the first cohort, one mortality. This is a 30-day mortality. So no on table or in hospital. That's but at 30 days, one mortality here. This patient actually collapsed at home and he was in Pune. We just don't have any idea why he collapsed. I would presume this arrhythmic and I put it down at 30-day death. This is another patient at mortality in 27. And this is actually, I think, Amit Vora's patient who came to us with AF and hypertrophic cardiomyopathy. AF was treated by shock and then he went underwent ablation. But within 30 days, he one fine day came from office collapse. And before anybody could get to him, he was dead. I think that still, I would class that as an arrhythmic death. ASCD implantation, the first cohort, none. But in the second cohort, I've had 2 patients for whom we've had to put an ICD later on, which is about 1 to 2 years. One of them, I think Dr. Amit Vora knows about. He had done the Holter on him, which showed a 2:1 heart block at about 3 years after his ablation. And along with that, there was non-sustained VT. He came across to me to have this implanted. I actually got a cardiac MRI done on him because I was surprised because on echo, there was no gradient. So when I got the cardiac MRI done, I found that in the apex of the LV and in the distal septum, there were patchy areas of fibrosis, which was about 25 to 30%. So perhaps the arrhythmia was not there, but the heart block was there required. So he had a dual chamber pacemaker with an ICD implanted. Peak CKP release earlier was high, 1/3 average. And the thing that we changed was this. I kept the indwelling catheters for a long period of time. I cut down the amount of alcohol and got super selective in terms of which septal artery I would ablate. So if the septal artery had 2 branches, I would selectively go down to one of them to find which is the correct area to ablate and then ablated that, which I hope would result in a smaller infarct, which is what it did, peak CKP. And I hope this will translate into better results. But clearly, the need for ICD implantation was higher in this group. Long-term survival for the first cohort, clearly more than 95% are alive. Now, the long-term survival here is all tenofolic. Clearly, patients come from all over India, so my girls get very efficient at doing that. And long-term survival has been pretty good. Here, of course, a lot of patients have been done in the last 3-4 years, so this is not 10-year survival. But suddenly, good results in terms of what patients are doing. So to conclude, effective relief of symptoms in the vast majority of cases, that's been great, no problem at all. Extremely safe procedure. Echo guidance has been really helpful in targeting where and how I should go and ablate. There's been a very good long-term relief of symptom. What has been very clear is that there has been no major long-term arrhythmic risk, which is very reassuring, but that kind of justifies what was done in the early stages. There have been repeat procedures for relief symptoms in small minority of cases. Unfortunately, most of them in the second cohort where I've tried to go for a smaller area of infarct, I've probably left behind some gradient. So clearly that strategy is backfired as far as second procedure is concerned, but except for 1 or 2, most have had a second procedure and they've done well. So clearly we need to rethink about what I'm actually doing in terms of trying to reduce the amount of infarction that I create, maybe some biomedia. So now my target is more like having a peak CPK of about 1,000, 1,200, which kind of looks a little better. So to conclude, this is a procedure that has been now well tried. It's been around for a long period of time. One of the criticisms was that we didn't have long-term follow-up. We now have long-term follow-up from 3 major trial studies from US, from Europe, and this is my data on long-term follow-up, and it's looking pretty reassuring. So it's something that we can use a lot. I'm actually looking forward to Dr. Verma talking about surgery because that's been something that's been lacking in our setup. We don't have people who want to take on surgery for this particular condition. Thank you very much for your attention.
Thank you, Suresh, for this excellent talk on the septal ablation. And now this last talk is Dr. Praveen Verma. He's going to talk on surgical myomectomy, on surgical management of the HOCM. So over to you, Dr. Praveen from Cochin.
Yeah.
Can you see my screen?
Yes, yes, you can see.
Yeah. First of all, thank you for inviting us, both me and myself and Hisham, for this wonderful gathering. So, the indication for intervention is pretty clear, that patients who have got refractory symptoms in spite of medical therapy, and they have got an LVOT gradient of more than 50 millimeter at rest or exercise, we tend to go for interventions. And as the previous speaker said, alcohol septal ablation has been there for some time, but alcohol septal ablation has been there for some time, but surgery in the past, probably in the last 10-15 years, has come into big work, because we have found that patients who have got alcohol septal ablation tend to have recurrence of symptoms. And what we used to do for septal myomectomy in the previous time has changed, because now we hardly have to do anything to do with the mitral valve. Previously, what people used to do was they do a small limited septal myomectomy and replace the mitral valve, which used to give the patient a bad diastolic dysfunction and a systolic dysfunction, and they don't do well. So now our need to do a mitral valve replacement is only if the patient has got any intrinsic mitral valve abnormality that cannot be repaired. So basically, what we now do is what is called as an extended septal myomectomy, where we go right down to the level of the papillary muscles. With this, the results have been excellent. And we do cardiac MRI for all the patients, because we think that it's a very good roadmap for us. And we also do an intraoperative transesophageal echocardiography, where our anesthesiologist actually measures 2 points. One is the maximal thickness of the intraventricular septum, and they also measure the distance from the aortic valve to the septomitral contact. In most of the cases, we get around 2 to 2.5 centimeter below the aortic valve as the septomitral contact. This is very important, because we have to go really right beyond this point to get a good result. And they also look at any abnormalities of the mitral valve. They measure the anterior mitral leaflet length. And if the anterior mitral leaflet length is more than 32 or 34 millimeter, we are little concerned whether we need to plicate the anterior mitral leaflet. We also look at the posterior mitral leaflet length, and we also look at the abnormalities of the mitral valve. So what is important in HOCM surgery is that we have to identify the correct mechanism of left ventricular outflow tract obstruction. So in Amrita, what we do is that we sit down with Hisham. Hisham is our program coordinator for hypertrophic cardiomyopathy. And we get the cardiac MRI, we get the echo, and we make a plan that this is the cause of LVOTO. So most of the time it is a thickened intraventricular septum, but when the intraventricular septum thickness is not that big, like let us say it is like less than 2 centimeter, then we start getting worried whether the abnormality of the SAM, systolic anterior motion, is due to the anterior mitral leaflet, prolonged anterior mitral leaflet length, or is there any abnormal papillary muscles that is getting attached to intraventricular septum or anterior mitral leaflet, whether it is a elongated posterior mitral leaflet that is the culprit. So the mechanism of LVOTO is actually the crux in HOCM surgery. So when you have a LVOTO, you get an MR. So this is very important. The previous speaker has told us that the severe MR is an indication for mitral valve replacement, but we now know that the MR, if is posteriorly directed, the cause of MR is actually because of the LVOTO, because the mitral valve gets opened up. And most of the time, I'll say that not most of the time, almost 100% of the time, when you do an adequate resection of the septum, the MR disappears. So if you get a MR that is central, or if it is anteriorly directed, then we look carefully at the mitral valve, saying looking at whether there is an intrinsic abnormality of the mitral valve. So basically, all these things, you are very well aware of it. So the surgery for us is called as the septal myomectomy. It's otherwise called as Morrow's procedure. It was described first by Andrew Morrow, who was working with Eugene Braunwald in NIH, National Institute of Health in Bethesda. So in Morrow's procedure, we do only a limited myectomy. We now know that this is not sufficient, and we need to really do an extended septal myomectomy. What is meant by extended septal myomectomy is that you go down right up to the level of the papillary muscles, base of the papillary muscles, and cut that septum out. So our idea is not to just cut the septum at the basal, anterior basal, this one, but we have to really go down to the base of the papillary muscles. So this is the difference between the septal myomectomy. On the left side, you say that the classical Morrow septal myomectomy, where we do a limited resection. This is associated with the usually recurrent obstruction, and the MR will not subside. But if you do, and on the right side is the extended septal myomectomy, you can see that the knife is almost at the apex of the heart. So at the level of the papillary muscles. If you do this most of the time, the LVOTO gets relieved and MR will subside. So I'll just briefly show you a video. So we always go for full sternotomy. I hope that you can see this video clearly.
Yeah.
And can you see the video?
Yes. Yeah, we can see.
Yeah. So we stop the heart. We're using cardioplegia because this, you can see that the heart is so hypertrophied. So we have to give a lot of cardioplegia to make sure that we don't get a post myocardial dysfunction. So most of the time, we can finish this surgery within like in one dose of cardioplegia. We use del nido cardioplegia. That's we use antegrade and retrograde cardioplegia to give a good myocardial protection. And then we do an oblique aortotomy. So you can you see that it is going right to the level of the non-coronary commissure, and then we retract this with an S-shaped retractor. This is a malleable retractor. This is given to the assistant, and the assistant is told that your retractor is below the aortic valve, and you have to be very, very careful. Otherwise, the aortic valve can get injured. Yeah. So this is a very small area. So what the forceps is showing is the mitral, actually the papillary muscles, the chordae attaching to the anterior mitral leaflet. So now we take this few stay sutures. Can you hear me?
Yes, we can hear.
Yeah. Yes. Yeah. So we take this stay sutures. That is the thickened septum. You can see in a normal patient, you can actually see the papillary muscles when you through the aortic valve. You can see the papillary muscles. But in hypertrophic cardiomyopathy, you will just barely see the chordae to the anterior mitral leaflet. So that is the thickened septum. So we make the first cut that is below the nadir or the right coronary commissure. So if you cut to the right side, there is a high chance of conduction blocks. So with this approach, the incidence of pacemaker implantation is usually less than 2%. So even if we require a pacemaker, we prefer to put an AICD in these patients. So that is the first cut what we make. And then, we have to go really down with this. So we use a 15-blade knife. So how much to cut is actually the judgment. That is the crux of this one. Is if you cut more, you can get a ventricular septal defect. That is very unpleasant. But we had that complication, and we can fix it. But it's a little bit of disaster. But then you have to go for a bicaval cannulation, open the right atrium, identify. So this is what we are doing. So we are cutting, like making a trough of cutting that muscle out to the left of the nadir of the below the right coronary cusp. So that is the first cut. Can you see that? Mm. Then we go a little bit to the right side. Can you hear me?
Yes, we can.
Yes. Yeah. So so we are going to a little bit to the right side. So if you go more to the right side, definitely it will end up in conduction block. So we typically aim to reduce the septum to less than 15 mm. That is our idea, and then we go down right to the almost to the apex of the heart. So this patient, which I showed, had a intraventricular septal thickness of around 2.5 centimeter, and she had severe MR preoperatively, and we did only the septal myomectomy because the anterior mitral leaflet was less than 30 mm, and we did not find. So this is the final result. You can see the base of the papillary muscles, the two papillary muscles, that's the posterior medial papillary muscles on the right side and anterolateral on the left side. And that is the cut we have. So it's like a clean cut there. And you can see we have to make sure that, all the chordae are intact, and then we close the aorta and come off bypass. So with this approach, usually we get gradients in single digits, and the MR disappears, or not, I will not say disappear, but it will become less than moderate. And that is what we aim. You can see in that echo that we have gone right below. This is actually taken from Nashimura.
Thank you. Yeah.
Yeah. So when the intraventricular septal thickness is less than 18 mm, we have to be careful about what are the abnormalities of the mitral valve. This is one of our patients who have got an anomalous band extending into the intraventricular septum. This is a well-known abnormality where the papillary muscle is directly attaching to the anterior mitral leaflet. We had to release this. And this is one of our patients who had you can see that very long, elongated PML, that is a cause of SAM, which we plicated. And there was no LVOT gradient, nor there was any MR. So I'll just briefly say about Andrew Morrow. So he was working with the Eugene Braunwald. So at one time, he was not feeling well. So he asked Eugene Braunwald, Gene, can you have a look at me? And Eugene Braunwald looked at him. That time it was before echo time. And Eugene Braunwald said, Andrew, you must be having a hypertrophic obstructive cardiomyopathy. Actually, he had hypertrophic obstructive cardiomyopathy, and he had a lot of issues. He had atrial fibrillation, he had a stroke, and finally he died. And this is the Morrow's heart. So the guy who actually invented septal myomectomy died of hypertrophic obstructive cardiomyopathy. You can see the thickened intraventricular septum. That blue line is where we actually now cut. That is right from below the aortic valve, around 1 centimeter below the aortic valve. If you go very proximal, then the base of the aortic valve can become very unstable and patient can develop AR, aortic insufficiency. So since it's an autosomal dominant disorder, two of Morrow's children also suffered from hypertrophic cardiomyopathy. The daughter refused to undergo septal myomectomy, and finally she had a transplant. This is the picture of her heart. You can see a lot of hypertrophy of the. And his other son also had a hypertrophic obstructive cardiomyopathy and underwent septal myomectomy and is doing well. And they have a kid now at 19 years, female. She's now diagnosed with the non-obstructive hypertrophic cardiomyopathy. So it shows how much is the autosomal dominant pattern. And the results are very good. Once you do a myomectomy, it's far better than non-obstructive HCM. And you can see that the survival almost matches that of general population. That is the beauty of this surgery, that if you do a beautiful septal myomectomy, then it's almost a cure. Thank you. Thank you.
Ramesh sir, you can unmute yourself. You can unmute.
So Praveen, for this excellent talk on the surgical management and myomectomy, which you have been doing it.
Sir, unmute yourself. Ramesh sir, you can unmute.
So I think Abhinav, can you share that slides? That's
Yeah, I will share, sir.
So I think we all talked about the genetics. There are actually just few slides are there, genetics and this hypertrophic cardiomyopathy. Go to the next slide. Think genetic implication. I think more than 1 in 200 have inherited form of heart disease, but most don't know it actually. That was the thing many people who didn't know that Dr. Morrow came to know it much later. An inherited cardiovascular condition may have few or no symptoms, but still face significant risk of heart disease, including sudden cardiac arrest, which Amit talked. Estimated, I think, 2095 the occurrence of out-of-hospital sudden cardiac death per year in the United States, only 0% survival rate and no priority. So genetic testing can help the lives. Next slide. So I think in onset from the infancy to late childhood, prevalence 1 in 500, maybe isolated this US data or Indian, we don't know exactly, maybe isolated related to broad spectrum of causes, such inborn errors of metabolism, genetic syndrome, or neuromuscular disorder. I think autosomal dominant I see is very common in the offspring. Individuals are usually advised against participation in the competitive sport, which actually Amit told it, but now with this surgery, and I think maybe we have to, since it is usually inherited and dominant manner, at least first degree relative should be referred for a cardiac assessment by a specialist actually in a familiar with HCM and to a genetic clinic for assessment of counseling and review of the genetic testing opportunities. Next. So familial hypertrophy is the leading cause of sudden cardiac death among young and apparently looking healthy people, quite common more in black people in India, yes, than the actually. It's usually caused by autosomal dominant, actually we already discussed, which is genes encoding sarcomeric and sarcomere associated cardiac proteins, and which has identified these additional genetic causes of HCM or targeted sequencing approaching, extending genetic screening in the deep into metal, INDB pathogenesis and variants of 9% gene elusive. These findings translate to more accurate diagnosis and management. I think this genetic testing do help us, at least in the close family contacts and all that thing will be definitely help it actually. And the type of genetic thing actually, various genes have been. Next slide. They have been actually the common genes are MYH7, beta myosin heavy chain, MYBPC, myosin binding actually protein C, TNT2, cardiac troponin T, TNT troponin actually the various at least 5 different types of gene. Most tests are panel actually they have been US actually testing multiple genes simultaneously in a package. Test sensitivity is currently around about 60%. People with hypertrophy associated with gene mutations are at high risk to develop HCM at any point of life, not just in early adulthood, as previously believed. They can at late presentation, which I've seen later. That's why every 5 years or at least we should have a follow-up echo in all these people we have suspected or in their family history. And purpose identify this causative, and this was one of the case actually 8 years know-how, a yearly back checkup. His mother Mary attends the appointment. She reports a few family history of hypertrophic cardiomyopathy and paternal grandfather highly anxious about the implications. Next slide. So I think this is the family tree, how it goes actually. I think we'll not go into detail. Next slide. We'll just, so I think positive genes mutations are detected, negative no positive genes mutations are detected, and variants of this significance alternate HCM related genes are detected, but there is insufficient evidence to determine if they are associated with disease. So always the gene present doesn't mean the disease. There can be some association, 60% it will be there. So I think genetic testing sometimes can cause problems actually because of this psychological problem. Next slide. So I think diagnosis once confirmed, genetic testing at risk relative becomes available. There is no genetic test available to determine the risk status of the relatives, and actually the test is not useful for high risk as the relatives actually clinical. These results are usually treated as a negative in this case. Next slide. So again, next, I think this was a family tree that in order to know that risk, the Martin would have to be affected, and Martin the most appropriate person, therefore the expert evolution and SCF surveillance recommendations are the first degree relatives. There are none for second degree relatives. Next slide. So I think the benefits of testing, I think what's most important, confirm this clinical diagnosis. It differentiates from other causes some extent, fulfills diagnostic criteria and these complex heart disorders, identify at risk asymptomatic and pre-symptomatic family members. That is most important. It can be screened out and at least they can be started at treatment early. Prognosis, identify patients and family members the highest risk for the life-threatening arrhythmias, aortic dissection, heart failure, and predicts response to even pharmacotherapies. Actually, these are the benefits of the genetic testing. Some of the facilities are now available in India. Next slide, last study. So I think genetic testing can result, of course, adverse psychological reactions to some extent, and of course, potential to the risk of sudden cardiac death. I think that needs counseling, and I think this is who people should go for genetic test. But I think first degree relative definitely been advised. Uncertainty due to genetic variant of unknown significance. That's why there's a problem with the genetic testing, and possible there will be in the US big problem with the insurance discrimination can occur once the genetic testing comes positive. They may not be covered for certain. That's a major challenge for the US people actually. But I think the first degree relatives at early screening for them at least definitely. Benefits are the informs avoid certain medications and after guides the lifestyle modification to avoid triggering these cardiac events like high sports and all those things can be avoided. Aids in decision to place the implanted cardiac defibrillator or pacemaker. Direct treatment options as an enzyme replacement therapy and surgical intervention or cardiac transplantation required cases. Enable approaches screening intervals and intervention at risk if the family members. So that's my just smart presentation on a genetic testing. Actually, the range of testing outcomes actually has been summarized. Assuming indicates hypertrophic cardiomyopathy. So the various genes have been also screened. But of course, there are some limitations of the genetic testing. Actually, we must know that. But it is definitely useful for the close family. So I think that we say. So testing and then say a guidelines and conscious statement by all this AHA, ACCF, and all that have all recommended in a wide cardiovascular diseases. Thank you. I think that was a short presentation. We have some facility now available in India also. So I think we go to the question answer. Ashish is ready. So I think we have some questions from our side and then whatever we got from audience. I know that also. Ashish.
Yeah, sure. Thank you very much. Very nice presentation from all the speakers. After a long time, we had something different to listen to, and I'm sure the attendees must have enjoyed it. I think there are certain questions that I had for individual speakers. I listened intently for last 1.5 hours. Obstruction as a marker of risk stratification has changed its position, and now there is an increasing belief that the level of obstruction matters to the SCD risk prevention. I think one question that I do want to ask Dr. Burkule is about evaluating the dynamicity of the MR and obstruction. What comments would you like to make on that? And another thing was that there is a certain overlap between HCM and non-compaction. So can you comment, make some comments on aspects?
Thank you, Ashish. So I will take the first question about the dynamicity of the LVOT and LVOT obstruction and MR. It's true because many patients who get labeled that their syncope or the symptoms are related to arrhythmias may actually have a very dynamic severe LVOT obstruction and a florid MR, and that may be pushing them into sometimes even flash pulmonary or even into syncopes. So it's very relevant that you have to exercise them and at peak exercise look at the LVOT gradient and also quantitatively find out the degree of mitral regurgitation. The preferred exercise is upright treadmill exercise and not pharmacological test. So they have to have an upright treadmill exercise, and peak exercise you do the stress echo and look at the dynamic LVOT obstruction and the increase in the mitral regurgitation. Second thing is that in anywhere up to 15 to 20% of the patient, the MR may not be only related to the dynamic LVOT obstruction, and there one has to be very careful evaluating the morphology of mitral wall either by transesophageal echo to look at certain variations, like say a papillary muscle directly inserting into the mitral leaflet, the size of the mitral leaflet. Sometimes the PML is quite elongated while the AML may be short, so and so forth, because they would definitely need a surgical correction rather than just relieving the dynamic LVOT obstruction. And about the left ventricular non-compaction, now interestingly, most of the sarcomeric gene mutations which are implicated in the hypertrophic cardiomyopathy are also implicated in the phenotype of left ventricular non-compaction. And sometimes you can see even chimeric patients, that is, they have a asymmetric septal hypertrophy, while the free wall may also show some kind of non-compaction. I know that the non-compaction is slightly overdiagnosed in the echo labs or also in the cardiac MRI, but if you remain with the strict criteria also, you can see the shimmer of hypertrophy and non-compaction in the same patient. Earlier, it was thought that the non-compaction puts the patient at a very high risk of sudden cardiac deaths or arrhythmia, but that has not borne true. They have the same risk of arrhythmias. Only thing is that one can develop clots into the non-compaction zone. if you so you hunt for it when you see a non-compaction. If you find it, probably that makes a case for anticoagulation.
Thanks, Nitin. I think it was very nice to listen to Hisham. That's new for at least the crowd.
Ashish, one more question to Nitin again.
Yeah.
The role
Sure.
of MRI, how frequently you're going to use MRI now for every patient hypertrophic cardiomyopathy? Do you need a MRI will add to your management part, or is echo sufficient for it? The MRI's role actually in HCM.
I think there are three different clinical scenarios where MRI comes in handy. First is that you have a significant ECG changes, and on the echo you fail to find a non-contiguous hypertrophic cardiomyopathy. I think the MRI, because of its excellent resolution and the inherent contrast of the LV cavity and the myocardium, the non-contiguous variety of hypertrophic cardiomyopathy can pick it up very well. Second clinical scenario is definitely before the myectomy, that you get a perfect extent, surgical extent. You can get that extent of hypertrophy, and one can plan it well before the surgery, which probably the echo may not give that kind of a panoramic picture. And the third thing is obviously the myocardial fibrosis, or the interstitial fibrosis, or the replacement fibrosis, where the MRI has an edge over echo. So when we'll have this large data about the role of interstitial fibrosis, quantification of interstitial fibrosis by T1 values, and the replacement fibrosis by LGE, having a robust role in predicting sudden cardiac death, then probably the role of doing MRI in all patients will be justified. But till that time, I think we have to keep our finger crossed.
Thanks, Nitin.
So one more question to Suresh. You said you will avoid the patient of MR, the septal ablation.
Correct. Yeah. I mean, if it's grade 3 MR, I would certainly try and look for.
And the surgical team says that they get MR get corrected after the surgical thing.
I think what is important is before I go in to do a septal ablation, to know what is the mechanism of the MR before I touch the patient. And for that, whatever that needs to be done, we need to be sure that we are not dealing with organic, we are not dealing with a aberrant papillary muscle sticking to one of the leaflets, you're not looking at something else going on there. And unless you're sure of that, if that is the case, then that's a surgical procedure. There's no doubt about that. So that's what I do. For my cutoff is up to grade 2, I don't worry too much about
grade 3 we should avoid.
Grade 3 and above, I start looking for a reason why I should not be doing this case rather than doing it. So that's the Vinay cutoff, and that's actually a lot in the long term. Unfortunately, the problem that we face over a long period of time is not having people who are willing to take up and do surgery for these cases.
Correct. That was the main challenge.
They've languished a lot, unfortunately.
Ablation, they get ready, but surgery is very difficult.
Can I just comment on the MRI? I think what is important is before we take the patients up for septal ablation or for myomectomy, and I think that's something increasingly I am doing, is look for remote fibrosis. We're all concentrating on the septum, which is looking at obstruction. But clearly, if the patient has some symptoms, pre-syncope, syncope, I think we need to look at the rest of the myocardium. If you've got patchy fibrosis in the apex of the LV or in the, that's not going to go with either treatment. That patient is at risk for arrhythmia. So if you want to treat the patient as a whole, clearly we need to do that, plus think in terms of an ICD or something for them.
So Suresh, it was very interesting from your series that only 2% of the patients had ICD. So is the patient HCM group requiring a relief of the obstruction and requiring a ICD different?
See, I think earlier, as even Amit mentioned, that obstruction and sudden death go together. They ran together all along hypertrophic there. But over a period of time, we realized that that does not translate into, if you have done an effective ablation, surgical or otherwise. I think once the gradient falls down, things do start changing. The hemodynamics start changing. The stress on the rest of the LV changes. So clearly, what was initially felt that maybe you're creating a scar and that would add to the risk of arrhythmias has certainly not been borne out. So certainly there is a need for, there's no need for an increased risk of ICD or ventricular arrhythmias with septal ablation and scar creation. So that was one issue there. Second is, yes, now that you've reduced the obstruction and you're allowing the ventricle to remodel, and actually we've seen that on repeat echoes, that as the gradient comes down, the LV starts to remodel. You now don't see that kind of huge hypertrophy that these patients have, and both from the surgical series and otherwise, you're not seeing that. So I think, yes, once the obstruction is relieved, you're changing the hemodynamics, and that's having an effect on at a cellular level, which would probably reduce the need. Now, having said that, if at the time of diagnosis you have a lot of patchy fibrosis, then that patient is at high risk. But earlier we didn't have MR, we only have MR now for the last 3 to 5 years. So we'll see now how the data evolves in terms of looking at. I am now, if the patient has any suggestion of presyncope, I do an MR before I take the patient up for
Thanks, Suresh.
ablation.
Thank you.
So I think that now will be a protocol to have MR before we go for either ablation or surgical procedure.
Yeah.
I think.
I mean, in terms of VT risk stratification, I think where do you put your weight behind? Is it the myocardial, is it the enhancement in MR that's more important, or a non-sustained VT on a Holter that is more important, or inducing a VT on a EP study that's more important?
Asking me, asking Amit.
Yeah, Amit. No,
okay.
sorry, Amit, that was. Yeah.
Correct.
Okay, so I think, let me answer from the last point, the EP study. So I did show that virtually there is no role for EP study in induction of ventricular arrhythmias for hypertrophic cardiomyopathy, because often you see ventricular flutter fibrillation kind of a thing, and they may not necessarily be reentrant variety. Now, if you have an apical aneurysm, then you are likely to have a scar and re-entry. So when you have a re-entry mechanism, VT may be more reproducibly inducible. But therefore, EP study is not actually a tool at all to predict who's at a high risk of sudden cardiac death or VTVF. As far as the various risk factors are concerned now, late gadolinium enhancement and myocardial scarring is a new kid in the block, I would say. It's been fairly studied. Large number of papers are there. So practically, we are almost all cardiologists managing HCM patients are utilizing that tool to risk stratify also in addition. However, I have to say that it has not come in the guidelines as yet. So when we have a more revised guidelines, maybe gadolinium enhancement might come up, because there seems to be sufficient data. There seems to be some heterogeneity in terms of the percentage of fibrosis. More or less 15% seems to be a cutoff value, but yet this is still an evolving field, and we don't have prospective long-term study validating the LGE score and risk. So I think we are left with conventional ones. So I think the most important is a prior history of cardiac arrest. I think that remains the most important. Family history of sudden cardiac death in first degree relative, that remains important. Left ventricular hypertrophy more than 3 centimeters, that remains important. Syncope is relevant, but a remote syncope again is not so relevant as a recent new syncope. And of course, I think age is probably the most important thing. Adolescents, adults up to 40 years of age, it's all good to risk stratify aggressively to see who needs the ICD. But beyond 40, 50 years of age, I think that age is kind of protective in terms of not allowing sudden cardiac death, and these are probably natural survivors.
Right.
Non-sustained VT you mentioned. Yeah, I think non-sustained VT is another thing which is, I would say, a little bit of a gray zone, though, because, if you do Holter study in patients with HCM, almost 1/3 are going to show up non-sustained VT. So is it by itself enough for you to recommend an ICD? And probably not. So with NSVT, you probably will require other risk stratifiers also to be present, and then probably it may have a weightage. The type of NSVT, I think, is relevant, because, by definition, we can say 3 or more beats up to 30 seconds. Now the heart rate more than 100, 110. I don't think that has much value or meaning. But if you had a 150, 160, 200 beat run, it was polymorphic in nature, I think I would be more worried with that type of an arrhythmia rather than 120, 130 beats a minute.
It's a nice clarification. Before we end, I think we are at the end of the seminar. But before I end, I want to engage Hisham in a discussion where he nicely said that diisoparamide, the main role was its negative inotropic effect to benefit the diastolic dysfunction and dyspnea. And he also said that one that could help in suppressing AF, and he never indicated that was for ventricular arrhythmia treatment, which is a nice thing to remember for the audience. He also touched upon mavasentan, that is the new
newest
once again. But what I want to ask him is the role of ACE inhibitors? I mean, they are anti-fibrotic in nature. Would they do anything in terms of the long-term prognosis of a HCM patient?
Yes. So this has been sort of a big glaring question in the field. If you look at the data of the last decade or so. And if you really look at the data, there have been a host of trials, and most of them are, small, uncontrolled trials. But then they have looked at whether there is a role, whether ACE or ARBs can act as a disease-modifying agent. So whether you can sort of have can you regress the degree of LVH if you prescribe these agents to a patient quite early in their natural history? Number two, can this drug sort of bring down the degree of replacement fibrosis in such a patient? So there have been mixed conclusions from these small trials, but I think some of them have clearly shown that they have had a favorable effect on diastolic function, implying that they've had a sort of an indirect effect on favorably modulating the fibrotic question. But I think the trial which might address this question is called the VANISH trial, so which is now looking at losartan and valsartan. So this trial is essentially based out from Brigham, and it's still recruiting. So essentially, this trial is now going to look at the data whether. Yeah, can you hear me?
Hello.
Yeah. So the VANISH trial essentially is now going to address the question whether you can use valsartan or losartan in a randomized fashion, placebo-controlled, and trying to find that whether ACE or ARB can have a disease-modifying effect in these patients. But to answer your question, in terms of available data, I think we have 6 or 8 small uncontrolled studies which have very conflicting information based on this study question. So I think the VANISH trial might throw some more light on it. Mechanistically speaking, they should have a favorable effect, but I think we need to see the evidence in the long term.
Thanks, Hisham. Before handing over to Dr. Dargad, we must compliment Dr. Verma for explaining that incision that really relieves the LV outflow tract obstruction. That was a quite informative talk from Dr. Verma. Back to you, Dr. Dargad, for concluding.
Before that, there is one question for Dr. Amit Vora from the delegate side. The person who has undergone AICD, can he take adventure sports activity?
So I think,
delegate has asked. I have not asked.
No, I saw that question. In fact, I replied in the chat box also. Yeah. When you have an ICD implant, generally speaking, all competitive athletic sporting activities are barred. You can't do that. In fact, abroad, even your driving license is taken away once you have an ICD in place. I think the philosophy behind that is that ICD is going to save your life when the arrhythmia happens. But the problem is some of these patients may land up with presyncope and syncope. And getting a presyncope while driving or while swimming or while doing competitive sporting adventure sports or what you have can be a problem. And therefore, I guess, despite having an ICD, I don't think that we can allow leisure sports. We can allow non-competitive sports, but we should not, let them get into serious events.
Competitive sports, yeah.
Right.
Can I just add one comment here? Yeah. We've talked about ACE and ARBs for hypertrophic cardiomyopathy. Actually, I would be more interested if ARNI could be used because scabutril has much stronger antifibrotic properties in combination with valsartan. So perhaps that is something that perhaps should be tried. It may actually give a positive result, but I think that's still up for grabs. I don't think anybody is doing a study like that, and I don't think anybody is going to sponsor that kind of study for this cohort. But that would be something far more interesting to look at, because the ACRBs have been tried and we've never had any good answers for it.
Sure, Dr. Ketan, you want to wind up?
Yeah, Doctor. So I think it was really a fantastic presentation by all the speakers. We had right from Dr. S.B. Gupta, Dr. Nitin Burkale, Dr. HCM, Dr. Suresh Vijan, Dr. Parveen Verma, Dr. Amit Vora, who had given a fantastic presentation. So overall, it was a very nice initiative which was taken by Dr. Ramesh Dargad and Dr. S.B. Gupta, making this symposium exclusively on HOCM, which was a great success. And of course, we would be thankful to our partners, unrestricted educational grant, which was coming from RPG, which was also without their support, it would have not been possible. And before giving just a final vote of thanks by Dr. Ramesh Dargad, if Abhinav wants to say a couple of words.
Right, sir. Thank you so much. Would like to convey our thanks to, on behalf of RPG Life Sciences and on behalf of Northeast New, to Indian Society of Electrocardiology and all speakers. And we at RPG Life Sciences is dedicated in the future for the better management of HCM along with all medical fraternities. So on behalf of RPG Life Sciences, thank you so much, sir.
Thank you, Abhinav. Is Dr. Dargad there?
Ketan, Dr. Ramesh has left. On behalf of Indian Society of Electrocardiology, you can propose the vote of thanks.
Yes. Yes. So I would like to thank all the faculty for giving their valuable time for this excellent deliberations. I would like to thank all the delegates who have participated, and of course our partner RPG for giving unrestricted educational grant. We at IAC will continue to do these academic activities in the future also. Thank you so much. Thank you so much. Have a safe further journey in the COVID era. Thank you so much. Okay, bye-bye.
Thank you. Bye-bye.
Thank you. Good night.